Pandey, eminent nephrologist from Alexis Hospitals, Nagpur, with us to discuss and share his experience about cytokine removal therapies in ICU and sepsis. And on the chair, we have two senior nephrologists, Dr. Acharya and Dr. Khetan from Kingsway Hospitals, Nagpur. And with us, over to the chair for further proceedings.
Welcome, dear friends. You all know Nishant, who is not only a very excellent nephrologist and transplant physician, but he is also well known amongst us as a very techno-savvy personality. During our annual conference, he had helped us a lot. Now over to Nishant, please go ahead with this very important topic of cytokine removal. And this is somehow related to acute renal injuries that we often see in the ICUs. So over to Nishant.
Thank you, sir. Thank you for that kind introduction. And just I beg your pardon for initial technical glitch. I hope everybody is able to see the slides now. So the topic for cytokine removal therapies in ICU came up all along past few years when we were dealing with the COVID-19 pandemic. And all of us have faced clinical dilemmas and intriguing situations where patients had a lot of end organ damage, multi-organ dysfunction, and we were at a loss as to how better we can help these patients and if anything is remediable in their situation. So today we'll try to go through a few cases and see whether our experience regarding the cytokine removal therapies has evolved, and we'll try to see if there are learning points from them. So our first case was that of an 82-year-old male, and he was hypertensive, had type 2 diabetes, and was already receiving steroids for COVID-19 at other city. By the time he arrived at our hospital, he was hypertensive and had a lot of cough, and his chest showed crepitations. He had undergone dialysis at his native city, but there he had developed hypotension. His lab showed neutrophilic leukocytosis, thrombocytopenia, and azotemia had started to set in, and procalcitonin was high. He had also received a dose of tocilizumab at Amravati prior to admission at dialysis hospital. The CT thorax was not showing a very good picture. So now we were pretty sure that we were dealing with a situation of cytokine storm, although we were going to learn a lot in this case. So to our the problem was that he was developing hypertension on conventional dialysis and could not receive any other form of therapy, and already received immunosuppression which could have been given. So on compassionate grounds, we started him on CRRT with a cytokine filter, which we were using for the first time at that case during the second wave. So to our surprise, by day 4 of hospitalization, the pressures had improved. The systemic examination showed better air entry in the lungs, and the azotemia had also decreased. So we were trying to see that what has gone better with the patients, in fact. So we could see that his initial IL-6 levels were very high, and by day 10, when he could be shifted to the ward, his IL-6 levels, although high at that time also, but had significantly decreased. And although he required a few sessions of dialysis even after stopping CRRT, his lungs had now started showing fibrosis. In contrast to this, for the second case, we had a 59-year-old female during last month who was hypertensive, type 2 diabetes, rheumatoid arthritis, and she was febrile on admission, and she too was hypertensive. So learning from our good experience during the past year, we also started her on CRRT with a cytokine filter. And although she did not have much of azotemia to begin with, her CRP levels were high. CT did not show a good picture. So by day 7 of hospitalization, she continued to require CRRT. We couldn't stop the CRRT, and the ventilator requirements were high. So when we looked at the cytokine levels had in fact increased. She continued to have high leukocytosis, thrombocytopenia, although the CRRT had done its job of treating the azotemia. But the patient succumbed at day 7 and her lungs continued to worsen on the fateful day. So looking at these two contrasting cases, that two elderly individuals having similar kind of pictures, same disease premise, but both had different outcome with the same therapy. So which patient would have been beneficial most from the cytokine removal therapy? What was the ideal time to start the cytokine removal therapy? And how long could have it been continued? Like in first case, we continued it for 4 days and the patient had a good outcome. While in the second case, we had to pull out for 7 days, still the patient did not respond. And which were the biomarkers that could have been the most appropriate to assess for decision making? These were the questions that were bothering us. So that is when we try to learn more about sepsis and the role of cytokines. I will not bother all of you with the sepsis definitions, as the sepsis 3 definitions have now come and detail us that this is the life-threatening organ dysfunction because of dysregulated host response to an infective stimuli. And the compartmentalization of having a definition as SIRS or septic shock or severe sepsis are only to give us a uniform criteria to look at the outcomes and to approach the patients in a uniform manner. But in fact, they are a continuum of the same pathophysiological process, and we cannot exactly say when the patient has landed up in organ dysfunction. So in this beautiful review about the pathophysiology of sepsis, one can see that when the bacterium and it's the product of cell wall, like in gram-negative bacteria, it is lipopolysaccharide. For gram-positive bacteria, it is the lipoteichoic acid. And it could also be the fungal and viral antigens. When they enter the bloodstream, the first response comes from the macrophages, and there is within 1 hour, there are peak levels of TNF-alpha. And when 3 hours have elapsed, the TNF-alpha levels are going down and IL-1 and IL-6 levels are going up. The platelet aggregating factor is also one important cytokine in these early hours. What happens next is that there is elaboration of the arachidonic acid metabolites, and there is elaboration of the complement and the coagulation pathways. So these IL-1 and IL-6 cytokines now trigger the T cell activation, and the T cell now release interferon gamma, and which then downstream lead to formation of granulocyte macrophage colony stimulating factor. When all these cytokine and stimuli converge towards causing endothelial damage, and that is when the procoagulant phase of sepsis sets in, and that leads to the end organ damage. This is a common phenotype of sepsis that we have seen. Although this might seem to be a very multiple component kind of pathophysiology, this actually is a very oversimplification of the process, because what happens is that each individual cytokine not only has the ability to promote the elaboration of the other cytokine, but also has the ability to promote its own production. So when it is not like a continuum of events, it is actually a web of events where several factors are playing on the production or inhibition of the other factors. What is the common denominator, although, is the endothelial damage, and endothelium itself then produces several cytokines, which leads to end organ damage. So now the question is, before the patient goes into a state of septic shock or a point of no return, can there be a point at the peak of the pyramid, say step 1 or step 2, where we can hold back the patient or maybe stop him from going down the cascade? So this brings us to the concept of systemic inflammatory response syndrome and compensated anti-inflammatory response syndrome. So what actually happens is that the body is meant to correct itself when there is a antigen exposure, whether it be bacterial or fungal or viral. What happens is that pro-inflammatory cytokines are released within first few hours. And what happens next as a second peak is the anti-inflammatory cytokines. And these anti-inflammatory cytokines are supposed to control the pro-inflammatory phase. And then what follows as a third phase is the procoagulant phase. But as might occur, as we have seen in the first few cases that we discussed, is that there is actually a monocyte deactivation, and there is an inability of the monocyte to further increase the pro-inflammatory phase, and there is an imbalance between the pro-inflammatory and the anti-inflammatory phases. So although the body should be in a state of immunohomeostasis, this imbalance between the pro-inflammatory and the anti-inflammatory phases actually leads to a state of immunoparalysis, where the patient goes into a state of vasoplegic shock, decreased peripheral perfusion, sky-high levels of lactate, and decreased cerebral perfusion. This is when we think that the patient has gone towards a point of no return. So had this been a linear form of cascade, that the sepsis is almost like an initial pro-inflammatory phase followed by an anti-inflammatory phase, things would have been simpler and we would have been better able to choose our patients because we knew when the pro-inflammatory phase had set in. But in fact, the pro-inflammatory and the anti-inflammatory phases are present coexistent with each other and maybe are in different compartments of the body, present, like there is a surge going on within the tissue level, and in the blood level actually there is an anti-inflammatory response that is going on, that is leading to the vasoplegia and the shock. So what we usually see is that by the time the patient has reached a tertiary hospital, they are into immunoparalysis phase where the anti-inflammatory phase has gone haywire, and in spite of the usual resuscitation measures, the shock does not respond. So one has to always think about what trajectory the patient is going through. And when we try to target individual cytokines, if we see that there are a sequence of events that is occurring, there have been several candidate molecules like steroids, which are pan-cytokine depressing agents, like agents like tocilizumab, which are directed towards the IL-6 receptors. Then there are agents like infliximab, which are anti-TNF alpha. And all these single cytokine-oriented agents have not proven their benefit because sepsis is not a continuum of events. It is actually a web of events. If you try to control one part of the events, the other part takes over and the patient still lands in sepsis. So the concept of non-specific or non-selective removal of the cytokines has been placed, and that is known as a peak threshold hypothesis, where the all multiple peaks of cytokines of pro-inflammatory or whether anti-inflammatory, all the peaks are decreased, and because the peak concentration of cytokine is not there, so the deleterious effects of the cytokines is avoided. So the very non-specific nature of cytokine removal polymers or the cytokine removal cartridges, in fact, is not a criticism, but actually a benefit which they can play towards restoring the immunohomeostasis. But we will see that when we actually apply this rationale to the bedside, things are actually different. So that is when we come across the concept of the cytokine storm. So we have had a few cases in like autoimmune disorders when the patients went into a severe cytokine storm, and they could only be detected when they were almost in a life-threatening situation. Because there is no uniform definition of a cytokine storm, there is a beautiful review about the cytokine storm by Feigenbaum, which all of us should read. And it summarizes the concept of cytokine storm in 3 cardinal points. That is, one is elevation of circulating cytokine levels. Second is acute systemic inflammatory symptoms. And third is secondary organ damage, which most commonly is the kidney, liver, and the lungs. So the concept of cytokine storm was initially formed during the Black Death, where the pulmonary macrophages elaborated an unregulated amount of cytokines, and that led to the mortality of the patient. Most of the deaths in 1918-1919 influenza pandemic were because of the virus-related cytokine storm. The nomenclature of cytokine storm was initially formed while describing the graft versus host disease, and it has all been almost 30 years now that this concept has been in place. The concept of cytokine release syndrome is almost like a parallel to this concept of cytokine storm, but it was more so described when muromonab or OKT3 was used. There is also a phenomenon of chimeric antigen receptor T cell therapy, which is used in lymphoma patients, and this activated T cells give rise to unregulated formation of the cytokines. And all of us are aware about the hemophagocytic lymphohistiocytosis, where the degranulation phase or the phagocytic activity of the macrophages is going unregulated, and they are almost engulfing all the marrow cells, and that leads to cytopenia and the patient leading to capillary leak and pulmonary exudates. So the cytokine from the earlier years, the cytokine storm has now gone into a phase where we are seeing it more often during the pandemic phase. The most important thing is to recognize one when you come across. Most often the patient will have fever, and the fever could be high grade. Along with this, the patient will have anorexia, fatigue, hypotension, tachycardia, and there could be skin rashes, arthritis, arthralgia, and the patient will have a lot of cough, dyspnea, and tachypnea. Along with this, there will be hypoxia. And on the blood phase, the patients will have cytopenia, anemia. They could have leukocytosis also. There will be coagulopathy and hyperferritinemia, hypertriglyceridemia. We all have seen are very common in cytokine storm related to COVID-19. What comes as an interesting thing is that elaboration of the interleukin levels have not been seen consistently, as in patients who have low levels of cytokines could still be in cytokine storm. And while the patients who have high levels of cytokine storm, cytokine levels, of course, are in a phase of cytokine storm. So what goes on downhill is the capillary leak syndrome and vasodilatory shock, and the patient goes into a phase of decreased organ perfusion. So what are the laboratory parameters? Non-specific markers like C-reactive protein are universally elevated, and they correlate with the severity. Hypertriglyceridemia and leukopenia are seen along with leukocytosis. And there is a complex interplay, as I just said, that not necessarily the levels will always be elevated. This we learned a hard way in just a case which I'll elaborate after this. But what we have seen in COVID-19 is that the highly elevated serum interleukin 6 level is found in severe cytokine storm disorders in COVID-19. And the higher the level of interleukin 6, the higher the mortality is a correlation that has already been proved regarding COVID-19. So when we come across a patient who has a clinical background of a microbial infection or an autoimmune disease or a drug exposure, we have to look as which of these causes could be underlying problem, and then we have to mark a trajectory as to how fast this cytokine storm is worsening. We have to do a complete workup for infection, complete laboratory assessment of kidney liver function on all the suspected cases, and we have come to realize that in these cases the cytokine storm is actually not a diagnosis of exclusion, but in fact it is a diagnosis of inclusion, where it is an umbrella term which encompasses a lot of immune dysregulatory phenomenon where there is end organ damage. So is there a central mediator to the cytokine storm? In the process just described, is there a single molecule which we can pick up and target so that we can provide a better outcome to our patients? We learned that TNF alpha was one such candidate, and there are a lot of clinical situations apart from sepsis where TNF alpha can be elaborated, like rheumatoid arthritis, like SLE, like in fact its name is tumor necrosis factor, so it is elaborated in the cancer phenomenon as well. And when it is injected into the body, it shows a typical phase of release of other cytokines of IL-1, IL-6, and IL-8, and it acts on the hypothalamus to produce fever, and it promotes production of activity of the polymorphonuclear leukocytes, and has direct toxicity on the endothelial cells, and it also causes myocardial depression. That is why it was postulated that maybe TNF alpha is the most centrally acting cytokine in cytokine storm. But it has been seen that patients in severe sepsis might also have very low levels of TNF alpha. The second candidate, and let us meet him, that is IL-6. IL-6, as I mentioned, has shown a consistent mortality outcome correlation as far as COVID-19 is concerned. But this IL-6 cytokinetics are actually very different when it comes to septic shock as a clinical scenario. What happens is that when there are increased level of IL-6, there can be actually deregulation of the IL-6 receptors, and the increased IL-6 levels in the serum does not actually correlate with the biological activity, and it has almost similar effects like that of TNF alpha. So when we go about describing the cytokines, we don't have a single candidate and we don't have a magic drug when this web of cytokine storm and sepsis related immune dysregulation is concerned. So as we got wiser about that, the level of cytokine is not going to guide us as regards the patient mortality and outcome. In this third case, we try to measure them even more frequently. So this was a surgical patient who had cardiomyopathy, and he was operated for a sigmoid tumor and had undergone a laparotomy with loop ileostomy. And by post-operative day 1, he was hypotensive. And as a usual resuscitative measure, he received fluid, albumin, and antibiotics. But by day 2, his fluid balance had gone awkward and azotemia had started to set in. By postoperative day 3, he was even more hypotensive, shifted to the ICU, and was started on inotropes. Even longer, on postoperative day 4, he became more hypotensive, and the output was not picking up very well. That is when we started him on cytokine filters. To our surprise, in this case, by utilizing the Osiris filter, we saw that the inotropes could be tapered by day 7, and the patient's hemodynamics had significantly improved. The azotemia had gone low, and the lactate levels had also improved. So when we tried to look at the cytokine levels in this particular case, we saw that pre-filter cytokine levels were initially on the higher side, but in fact, post-filter they had increased, which was very confusing for us because we thought that the filter is actually supposed to remove the cytokines. But when we saw the cytokine levels on day 2, the net levels of pre-filter and post-filter cytokine levels were getting decreased, which also corroborates with our first few cases where the net level of cytokine was coming down, but the absolute level of cytokine was all over the place. That would not help us in correlating any kind of a rule as to whether a particular cutoff of cytokine is important when choosing our patients. So having learned this hard rule about that the level of cytokines could be different in tissues, different in the serum, different with different clinical scenarios, it was important now to look at various other parameters where we could find that this particular patient is in a state of cytokine storm, yes or no. And after we have identified based on the clinical criteria, the multi-organ dysfunction and the hyperinflammatory state, if we take those criteria as that of cytokine storm, not only the cytokine levels, the conventional dialysis has a very limited capacity for cytokine clearance. So the technology is now evolving into developing membranes which are more and more sophisticated to remove these middle and higher molecules. As we see that our conventional dialysis membranes have usually a cutoff of 30 to 35 kilodaltons, and only the low middle molecules are removed, while the higher molecular weight molecules like IL-8, IL-6, and TNF-alpha, which are our cytokines, are hardly removed by the conventional dialysis membrane. So the candidature of CRRT or dialysis as an immunomodulating therapy has been challenged, and it is no more true. So we want even more evolved membranes to remove cytokines if we postulate that their removal might change the natural history of the patient. So the Sorman technology has now become advanced, and we have come a long way from the charcoal filters. Charcoal was a very important adsorptive compound which had the capacity to gel a lot of inflammatory mediators, but the problem was bioincompatibility. This problem of bioincompatibility was overcome by coating the charcoal with several resins, but then the cutoff of these resins became a hindrance when clearance of molecules was concerned. So now we have come up with polyethylenamine engineered matrices where there are several fibers of polymers which are coated and composed into cellulosic beads, and these beads are fitted into a cartridge, and blood is made to flow through these cartridges. When we see that the extraction ratio of cytokines when examined pre-filter and post-filter, there's actually a 5 to 18% of removal of cytokines when blood is made to flow through this kind of filters. But again, the problem of bioincompatibility cannot be done away with. So that is why there are several designs where a sorbent cartridge can be used. Either it can be used as the blood to first flow in and then goes into the hemodiafilter so that all the metabolic abnormalities are taken care with, or there is an additional hemofilter at the start of the session, and then the blood is flowing to the sorbent and then going to the hemodiafilter, where again dialysis is happening, so the metabolic parameters are now dealt with. And even more sophisticated is the coupled plasma filtration and absorption, where there is a plasma filter. It separates the plasma first so that the formed element of the blood do not come in contact with the sorbent. And after the sorbent cleans the plasma of the inflammatory mediators, then the formed elements and the plasma both go to the hemodiafilter, and then the blood is returned to the patient. So these are the different variations in circuit to overcome the bioincompatibility problem of the sorbents. The sorbent technology has now been advanced to even more refined cartridges, where the membranes are evolved in such a manner that endotoxin as well as cytokines both can be adsorbed by utilizing the adsorption and the convection technology. So available with us are several cartridges like HA330, which is a synthetic resin polymer neutral macroporous resin with a large surface area. This is marketed by the Jaffron from China. Second is Oxiris, which is an AN69 membrane-based technology, which has 3 layers to it, which is first is the polyethylene amine layer, which has the capacity to remove the endotoxin. And then there is the AN69 membrane, which has the capacity to remove the cytokines. And all these 2 layers are now coated with heparin to give a regional anticoagulation. Then Cytosorb has been existing in the market since very long, and it is in fact a very large surface area sorbent cartridge, and it has a polyvinyl benzene copolymer beads, and they are further coated into other polymer layers, and they have a capacity to adsorb hydrophilic molecules from 5 to 60 kilodalton. But the ability of this Cytosorb is only to remove the cytokines and not the endotoxin. The Japanese have come up with a technology which is highly efficient in removing the endotoxin, and that is the toremixin, in which the polymyxin B, which has a very good gram-negative activity, is embedded into a polystyrene fiber, and the absorption leads to significant levels of removal of the endotoxin. So, what is the evidence in support of all these sorbent devices? If we look at the bedside experience as to the worldwide literature, we will be not be surprised that they are more or less similar as to all these sorbent cartridges actually give a very good hemodynamic improvement. They do cause a log reduction in the cytokine levels, but the mortality outcome is not very promising. The initial evidence came from the UFAST trial published in the JAMA in the year 2009. And they had a very small subset of patients, 30 patients, whom underwent the cytokine removal therapy with the cartridge that was the toremixin. So the effect of targeted polymyxin B hemoperfusion was studied, but the sessions on the mortality, there were actually no reduction in the 28-day mortality. But when the subgroup of this trial was studied, it was seen that actually measuring the endotoxin level, apart from the cytokine levels, give them an important clue that the cytokine levels of 0.6 to 0.89, who otherwise had a predicted mortality of 80 to 89%, were benefited from the therapy and not other patients. When you look at the evidence in support of the clinical utility of cytokine hemadsorption, that is the Cytosorb, it is seen that the extracorporeal blood purification using cytokine hemadsorption therapy has been shown to normalize the cytokine levels, but actually this is not consistently translated into the proved patient outcomes, and the jury is still out. In favor of Oxiris, there is a propensity score weighted retrospective study, not a prospective study. So this shows a decrease overall observed versus expected 20-day all-cause mortality. But this still is not a properly designed randomized controlled trial. So when we summarize all the evidence, there are a few case series where the utilization of the oxyris or the utilization of torimixin or the utilization of cytosorb have given rise to better hemodynamic parameters or better reduction of the cytokines, but there was actually no difference between the reduction of SOFA score and no difference between the mortality outcomes. In fact, there are a few trials where a log reduction of IL-6 levels were also not observed. So when we actually look at randomized controlled data, we don't have much to support us in regards to the benefit of cytokine adsorption cartridges. So this brings us again to our perplexity as to, since we don't have a robust evidence, which patient would benefit from the most from the cytokine removal, and when should we start the cytokine removal therapy in sepsis, and how long should it be continued, and which is the biomarker which should be the most appropriate to assess for the decision making. In our process of trial and error and utilizing cytokine therapies when it was absolutely mandatory, we have come across a few thumb rules, and those are that the patient who is a non-responder to standard medical treatment should be a candidate for cytokine removal therapies. The clinical picture of hyperinflammation, that is onset of shock with NORAD requirement of 1 microgram per kg per minute, or rapidly increasing noradrenaline requirement in the last 24 hours, or is already in a state of positive balance, should be considered for cytokine removal therapy. Development of at least one organ dysfunction, renal, respiratory, coagulation, or neurologic should be there. And the most important target of cytokine removal therapy are the decline in the sepsis markers like lactate, procalcitonin, CRP, endotoxin, etc. So when we look at all these 4 points, a patient who is not in hypotension, not in multi-organ dysfunction, should not be considered, and these are definitely the areas where we should not be considering the cytokine removal filters. Where we could be utilizing the cytokine filters is open to everybody's judgment and their own clinical experience as far as the patient care is concerned. Now we have come upon a cytokine-driven paradigm. When in doubt as to whether there is going to be a clinical benefit about cytokine-driven therapies or cytokine removal filters, we actually look as to whether the patients have acute kidney injury, or even without kidney injury, do they have a very high levels of septic shock with endotoxemia. Actually, we are in a process of obtaining these endotoxin activity assays, and we have requested Dhruv Pathology to make it available for us. But as soon as they are available, we are trying to incorporate it into our clinical workup. So if the patient has septic shock with endotoxemia, then the endotoxin adsorption with polymyxin or oxyris filters can be done. And if septic shock is there with cytokine storm and there are very high levels of IL-6, like more than 1000 picograms per ml, at that time cytosorb can be used. So there are a few parameters which can still give us a guide if the other parameters are not clear. So dialysis therapies have now come a long way from the Kolb-Brigham dialyzers to this cascade hemofiltration, where we have placed plasma filters in continuum with the dialyzers. And here in these pictures, you can see on the first left-hand side, we have utilized the cytosorb filter as a pre-filter device to the hemodialyzer. And in this second picture, you can see the torimixin filter that is placed as a pre-filter device to the hemodialyzer. And we are now routinely utilizing the citrate anticoagulation, because all these filters, when they are placed in series or in parallel, require a lot of anticoagulation requirement, and it is not possible to maintain the circuit for a long period of time unless you are utilizing a regional citrate anticoagulation. And more so, we have now come upon a concept of renal support rather than renal replacement, where oxyris and other filters can be utilized as a bridge until the underlying condition can be corrected, rather than the only therapy which is going to become a magic bullet and is going to change the outcome of the patient. The only prohibiting thing is the cost, because the cost is almost prohibitive for most of the patients who cannot afford it. But like it is always said, that there is no medicine like hope. and there is no incentive so great and no tonic so powerful as the expectation of something better tomorrow. We hope so that all these technologies are now incorporated at a much more public health level, and if they are available at an affordable cost, they sure have a pathophysiological rationale. And there are at least a few selected patients who have a very single hit pathophysiology, like a patient with abdominal sepsis who has just gone a bowel injury, or a patient with pancreatitis who just have a cytokine storm and does not have septic shock. These are a few cases where we can actually utilize these filters and make a difference to the patient's clinical outcome. And at the end, what we want is a satisfied and happy patient's face, and that is what is our clinicians take away from the entire medical field. Thank you.
Excellent.
Ishan, you have spoken wonderfully on a topic which is not very common, not being used by most of our colleague nephrologists. And I think whatever literature might be available all over, it is our own experience in the given situation which counts and give us the more confidence in using a particular therapy or treatment for the given patient. And the experience which we get will not be the one what we get read from the books or whatever is given in the textbook. And the more and more we do these procedures, we'll come to know what are the problems associated, what are the benefits associated with these particular therapies. And over maybe 1 year, 2 year, 5 years down the line, if we have done a particular number of patients, then we'll be able to know whatever questions you have posed, which patient, which markers. So I think it will be all by experience, and maybe if it is our own experience, that is the best thing. Then learning from people outside, because our working conditions are different. Our patients' affordabilities are always an issue. So maybe now we are into corporate hospitals, and there are patients who are coming from empanelments. There are, I think, patients where cost is not an issue. We may be using such novel therapies and collect our own experience. So I think whosoever has done these procedures in our colleagues, they can also share their experience here and contribute to what Nishant has told us today.
So one thing I will share now is that the cytokine levels are costing almost like 2,500 rupees for one TNF alpha level. And the cost of measuring one IL-1 A level is almost 10,000 rupees. So what we have come to know is that measuring the cytokines at such high cost will not tell us anything about the actual biological activity of the cytokines within the body. More routine parameters like procalcitonin, like CRP, like a good clinical examination will tell us more whether the patient is in the cytokine storm rather than having the absolute cytokine levels. And they might actually increase after the cytokine therapy rather than having an absolute reduction. So this has occurred many times.
What is the total cost involved, Nishant, in particular one therapy, and how long once you start the therapy, how long the filter lasts, and how many days the therapy is to be continued?
Sir, initially we had a very bad experience because when we were utilizing heparin, most of the patients had liver failure and we were not able to utilize heparin. So when we started utilizing regional citrate anticoagulation, we could almost have a filter life of 80 to 90 hours. So the cost of these filters are variable because each cytosorb filter will have a maximum retail price of 94,000 rupees. Each Oxiris filter, because it's an embedded filter within the system and it is not available as separate cartridge, it has a cost of 80,000 rupees for Oxiris. For the HA330 filter, the cost has now gone down, but it has a lot of heparin requirements. The cost has now almost reached 40 to 45,000 rupees. And for the most expensive one, that is the toremixin filter, the cost is almost like 1.2 to 1.3 lakh rupees for a single cartridge. So if by our effort we are able to pull on this cartridge for the entire session of 3 to 4 days, then it at least can be a bit more affordable for the situation. But if the filters are going to clot every time, then it is almost like an undoable therapy. And when we are stuck into situations where there are no other way to go, and we are utilizing these therapies, then we have to be a bit more careful as to which investigations we are doing, how many filter changes we are doing, because the cytosorb literature asks us to change the filters every 8 hours.
In the first patient, you had the patient had also received tocilizumab.
Yes.
So probably the tocilizumab also helped in recovering of that patient along with the cytosorb therapy. And in the next patient, I think second patient, she didn't receive tocilizumab.
She did not receive tocilizumab, and in fact, there was one interesting finding in the second patient, that as long as the CRRT continued, she in fact had a very good urine output. The urine output was almost like 60 to 70 ml per hour. The inotrope requirement had gone down. Almost we were able to taper off the inotropes by day 3. But because there were financial constraints and the CRRT was stopped on day 4, as soon as the CRRT was stopped, the evening of that particular day, the urine output dropped and the inotropes requirement again went high. So it was almost like a learning that the CRRT and the cytokine filter was doing a job of removing the cytokines continuously, and that was helping the end organ perfusion. But as soon as the therapy was stopped, the entire pathophysiological cascade again rebounded, and the patient was again in septic shock. So that is how she could not make it, and ultimately we lost her.
Do all patients require simultaneously CRRT also, or they can be managed with hemodialysis plus?
Sir, there are two filters which can be used independent of the CRRT platform. One is the toremixin, and the other is cytosorb. So if there are not very high inotrope requirements and the patient can tolerate a blood flow of 200 to 300, then we can utilize the toremixin and cytosorb on a 4008 machine as well. And there is a new cartridge that is available, that is the hemophil cartridge. So this is promoted by the same company who has toremixin, but toremixin is more for endotoxin removal, and hemophil is more for cytokine removal. So even hemophil can be utilized on a 4008 platform. So there are 3 filters which can be utilized. But Oxiris is a very closed system where it has been designed for a CRT platform. So you cannot utilize Oxiris filter apart from a CRT situation.
But CRRT alone itself can lead to improvement in hemodynamic status, like reducing lactate, improving blood pressure over a period of time, reduction in NORAD requirement. All those things can be delivered by a CRRT alone. So when do we combine both CRRT as well as cytosorb?
Yes, sir. There is a very valid point here, because actually we think that the cytokine filter is helping the hemodynamics, but a lot of buffer going through the CRRT, the pH change, and the lactate removal might actually be helping the hemodynamics and not the cytokine removal. But when experiments are done on the advanced platforms as to absolute removal of cytokines, then the CRRT filters, which have a cutoff of 30 to 35 kilodaltons, then they are not able to remove these cytokines. So in situations where you have a very high level of cytokine, where you think that the patient has one hit pathophysiology of sepsis, like abdominal sepsis, and when there is almost multi-organ dysfunction that is setting, those are specific situations where we would use a cytokine filter apart from a conventional CRRT. As for any other patient whom the cytokine levels are not very high, they don't have very high inflammatory markers, and only renal dysfunction is the concern, then conventional CRRT can also help in correcting the pH and improving the hemodynamics.
So you had 3 patients and 2 of them were COVID. Third was non-COVID patient.
Third was a post-operative patient who underwent sigmoidectomy. And he went into septic shock on the post-operative day 3 and it worsened on day 4. And he was not responding to the conventional therapy of fluids, antibiotics, and dialysis was not possible because he had cardiomyopathy.
There's a question from Dr. Prashant Malviya. Does high procalcitonin indicate cytokine storm?
Yes. In fact, it is very true because we have burnt our hands in considering only the cytokine levels as a marker of cytokine storm, when actually they are not. Procalcitonin, CRP, the clinical examination, and the correlation of the entire clinical situation is actually the important premise where we decide the patient is in cytokine storm. And procalcitonin levels has been shown to be the most important marker in monitoring the sepsis. Although there is one caveat there that procalcitonin might be removed by the cytokine filters or the CRRT filters. So they are not an important tool for follow-up. But yes, while deciding to initiate, procalcitonin is a very good tool and a very important tool, in fact.
Sir, I have a question. May I?
Yeah, please.
Yeah.
Am I audible, sir?
Yes.
Yeah, Gerald, we can hear you.
Sir, first of all, very excellent presentation. Really liked it. And really thank you so much. My question is that does these therapies are more helpful in bacterial septicemia, or are they more indicated in viral septicemia?
So both viral, fungal, and bacterial, if they are in a dysregulated phase where there is a huge imbalance between the cytokine levels, and you feel that there is no other way where you can treat the patients, it can hold good true for any kind of microbial etiology. In fact, there are several non-infectious conditions like drug-induced cytokine storms, like autoimmune disease-induced cytokine storms, where they can be utilized. And in fact, they are also utilized intraoperatively. When Cytosorb has got the FDA approval for utilization in post-CABG situations where there is a drop in urine output, or intraoperatively, if there is a bowel injury, you can straight away put the patient on an endotoxin filter. So these things have already been done. So there is a wide application. Only their bedside validation and uniformity in practice is not there because the outcomes might differ.
Right. So another thing is that looking at the cost of the therapy, where does therapeutic plasma exchange stands vis-a-vis versus adsorption?
Yeah, so that brings us also to high cutoff dialyzers, because the high cutoff dialyzers have a pore size of more than 5 nanometer, 5 to 10 nanometers. So plasmapheresis is just like those high cutoff dialyzers where you are removing the inflammatory cytokines, and when you think that they are the culprit in causing the problem. This has been postulated in acute liver failures, where there is an immune-mediated liver failure and you think that a cytokine-mediated disease is causing the problem. But what also occurs is the removal of beneficial compounds like the antibiotics, the beneficial compounds like albumin. So one might end up losing a lot rather than helping the patient at the end.
Right, sir.
Nishant, I have a curiosity or a question. Excellent presentation, good grip on information surrounding the various filters, and great experience that you shared of your own. In terms of level of evidence, what is the highest level of evidence that these filters have achieved in terms of the studies that have been done? So that is one. And second is, where are the guidelines in terms of supporting this as a standard of care? So I'm just curious about this. I don't know as a first hand.
Sir, in fact, during the COVID-19 pandemic, Cytosorb got the FDA approval for utilization of it's utilizing a cytokine removal device in COVID-19 situations. But when it comes to sepsis therapy, none of the randomized control trials have shown any evidence. So it almost comes like a suggestion, and nowhere it is coming as a recommendation.
Mhm. Sir, one more question. One important marker out of all these 6 markers, which you may suggest, or rather you may prefer to consider or to take the patient towards a cytokine storm. Apart from see, even IL-6 is not very definitive, right?
Yeah, we
So
all have learned that.
so one important marker which you could really suggest. Okay.
Sir, like I said, we were curious to get the endotoxin assay, because the endotoxin assay which we do for the dialysis water quality cannot be applied for the serum estimation of endotoxin. So it's a
Right.
different kit that has been used. So the endotoxin activity assay, if it is available, and it can be utilized to look at patients who have undergone some bowel surgery or have intra-abdominal sepsis, then they have a very cause and effect relationship between the elaboration of the culprit molecule and the ultimate pathophysiological outcome. So this is one endotoxin activity assay which I would definitely like to use in future, along with other markers which we have discussed today, like CRP, procalcitonin. Measuring IL-6 and TNF, yes, you can do that, but that is just additional information where you can collaborate everything and just put it all together.
Right. Thank you so much, sir.
Hello, sir. Can I say something? Sir, actually, in Hyderabad, what they used to do is they used to, for initiation of the cytokine filter, they used to do procalcitonin.
Yeah.
Yeah, yes, sir. And then in the follow-up, what is the response for the patient? They used to choose the lactate as a marker for the response part, for initiation procalcitonin, and for the response lactate. Second thing is, sir, hemophil also came with the that he is also hemophil that they are also helpful in removing the cytokines along with hemodialysis. So what do you think, sir? They are using it for 12 hours. It is a cheaper version. It comes at the cost of 25-30,000 as compared to the Cytosob, which is like 84, 90,000, and Oxer is also same range. So hemophil, any suggestions about that, sir?
Yeah, exactly. And
Hemophil
as you
filter,
said rightly, that procalcitonin is to answer the first part, is that procalcitonin is good for recruitment. It is not good for follow-up. Lactates and inotrope requirements are the most important parameters when you look at follow-up. And as for hemophil, in fact, hemophil in conjunction with the other endotoxin removal filters as a cascade filtration has also been utilized in trials. Like you use one filter for getting the endotoxin removed, and then you have the other downstream filter for getting the cytokines removed. So that is known as a double filtration process that has been utilized. To utilize hemophil in isolation, we have to look for more situations where there is almost like a non-infectious cytokine storm, where there is a huge rise in cytokines, but you don't think that endotoxin might be at play, or you think that the endotoxin phase has already been passed off, and now it is only the cytokines that are causing the damage to the patient's hemodynamic condition. And of course, hemophil can be utilized out of the CRRT platform, and it is very much affordable also. In our center, we have utilized hemophil only once or twice when we were utilizing it along with along with the toremixin filter. So I personally have a very limited experience about hemophil, but yes, they do have a rationale.
I think Manish is there. Manish and Amit had used the Cytosob in COVID patients. Can they share their experience? Manish?
About Anand? Anand, do you have any experience in using this?
Hello, sir. No, I actually don't have any experience using these filters. Never used in the past.
Prakash,
She's offline, I think.
Prakash,
Yes, sir.
do you remember one injectable which was released in the market about 15 years back, and which was
Yes, it
used left
costed
and right?
3.5 lakh rupees. It was used to treat cytokine storm. I
Yeah.
don't remember the name. I was trying to recollect the same.
Dotrigogen alpha. That is activated
was that?
protein. Dotrigogen alpha.
Some 15 years back, there was one drug, and it was used left and right by the intensivists. saying that, and then they said that if you use it very early, then it will give the response. Of course, this the technique that you are saying is totally different from what was used earlier. That was a drug, while it is a filter. These are the filters.
It was Zigris, if I'm correct, sir. If I remember correct.
What is that?
Zigris.
Yes.
Yeah. There was activated protein C.
Yes.
Yeah.
That was activated dotrigogen alpha. Yeah.
Yes.
Yeah, so it is interesting to note, sir, because once there is lipopolysaccharide elaboration, there is TNF alpha and IL-1, IL-6 release. And after that, there is the anti-inflammatory, that is the IL-10 and IL-4 release. And after that, there is the CRP as well as the activated protein C release. So when we are trying to target each of the individual molecules, the pathway might take over from the other side, and the patient might still have a problem. So when we say that early use of Zygris might actually turn the situation around, does not seem to hold true, and maybe that is might be the reason why it has gone out of favor.
So what is the anticoagulation used for these filters?
For these filters, most of the time we are utilizing the regional citrate anticoagulation, because they are very expensive filters, and we had very troublesome experiences when they would clot within 12 hours of their installation, and it was not doable economically.
But the Fresenius machines, we externally use it. Huh? Baxter, I think, allows. For the Fresenius setup, do you give like citrate externally or?
Yes. In Fresenius setup also, you can utilize the regional citrate anticoagulation, because citrate you are either utilizing as a concentrated solution, that is a 4% solution of citrate, that is a trisodium citrate, or utilizing it as a 1.8% solution in mixed in the replacement fluid. So if the replacement fluid itself has citrate in it, and then it is being circulated into the filter, we can actually monitor the pre-filter calcium levels and the post-filter calcium levels and try to see whether the calcium is being chelated adequately. So even with the Fresenius platform, citrate can be utilized very nicely. So that's not a problem.
Okay, thank you.
Ishan, can we use this as a preemptive therapy rather than using it as a rescue therapy? We are using this as a rescue therapy, but can this be therapy, preemptive therapy, where the patient doesn't go bad, and before that only we use that cytokines, cytosol filter?
I actually find it a very valid question, and initially in a few we began all these therapies 2 years ago, and initially I was very enthusiastic. I thought that this would make a lot of difference. And when we started utilizing, we saw that most of the patients were not benefiting. The reason was that maybe inotrope requirement to go down is one important parameter and one important premise which we have to consider. A patient who is not on inotropes, then we don't have any endpoint as to how long we'll continue the therapy, because we are starting, the patient is good hemodynamically. By day 3 or day 4, the cytokine levels have gone down, but the end organ damage remains the same way. So we don't have anything to go by. Second is that there is another pathophysiological correlate, that maybe in very early phase, these cytokines are actually trying to do the repairing process of helping the body to cope up from such a big antigenic challenge. So when we do it very early, maybe we'll do more harm than benefit. So maybe these things, so we have not utilized them as a preemptive therapy. We are more utilizing them as a rescue therapy.
In fact, in one of your slides, you have shown pro-inflammatory cytokines and anti-inflammatory cytokines. So the pro-inflammatory cytokines might be actually helpful in correcting the disorder rather than anti-inflammatory ones.
Yes. So the person who is not into multi-organ dysfunction, the person who is not having any inotrope requirement, maybe if there are no other constraints and everything can be done, so we can utilize this. At least we know that if we are good at our catheter techniques and we are good at utilizing the anticoagulation, the therapy will not harm the patient. But what good it will do is like anybody can guess as to what good it can do.
Sir, I have a question for everyone. How is the experience with that injectable EDTA? Very few reports are there. Like, does it really, is it really helpful in septicemic shock, or it's not? Injectable EDTA.
It chelates the calcium, right?
Am I audible? Am I audible?
Yeah, the EDTA, it is a chelating agent for calcium, is not it?
Right.
And people have used it for coronary artery disease. And about the inflammatory conditions, I don't know.
Sir, I would like to take that question. Injectable EDTA is considered as an antibiotic resistance breaker. So apparently, it's used as the last resort and it's not supposed to be used upfront. Like EDTA is conjugated along with meropenem, it's called Mero-DT. And it's also conjugated along with ceftriaxone, and that's an expensive drug. So these drugs are antibiotic resistance breakers, and EDTA functions as it breaks the cell wall and increases penetration of antibiotics into the cells. So it should be used as a last resort, and these are effective. These are effective. Even after meropenem and teicoplanin fails, we have used these antibiotics and we have found response. But then it should not be commonly used.
And how is the effect on those patients who are on dialysis, rather using heparin, using EDTA in such a patient, in such a scenario? Is
Just
it
EDTA as in a separate drug I have not used, but
no,
as
not
a
as a
combination
separate
along
drug.
with the other antibiotics I've used
Not
in
as
the
a
past.
separate drug, but with combination of antibiotics on a patient who is receiving some renal replacement therapy.
So the same modification that we use for the meropenem, we have been using it, sir. But I found the response was good. But then I have never looked into the literature and all. But I had worked with a critical care consultant who had actually exposed me to these drugs. But then when he used to use it, there used to be we used to get response even in cases which have failed the topmost antibiotics, because many of the times patients are referred after they have got most of the high-end antibiotics.
Even
so
we often see those patients who are pan drug resistant.
Yes. For those cases, it is useful. Yeah, for those cases, it is useful. But then judicious use should be promoted. That is the only thing. We don't know since there's not a lot of data on these drugs.
That's what right.
Can be used as a last resort if the patient is salvageable. That's what we used to consider as important. Like in certain situations where we know that we should salvage the patient, and not just because of the multi-drug resistant, we should lose the patient. I think we should use these drugs judiciously. And we should definitely promote checking resistance patterns to these drugs also, in case these are becoming widely used.
Right.
So responsibility vests on us to judiciously use these drugs, because we are exposed to patients who already have got exposed to multiple drugs. So we have to cautiously use them.
Right. Thank you.
Anything, Dr. Nishant, about cartridge saturation, the sorbent cartridge saturation? So in an event of a properly functioning kind of a cartridge for more than 24 hours, so are there any points clinical that there is an indication for an empiric changing of a cartridge?
Thank you, madam, for that question, because the purpose of today's discussion was to bring all these points into consideration, because there are so many things that are being promoted by the industry. Like Cytosorb manufacturers, they mandate that the Cytosorb cartridge should be changed like 8 hours after the therapy has been going on. and maybe a rebound increase in the inflammatory markers, or the rebound increase in inotrope requirement or worsening of shock tells us that the cartridge has been saturated and all the cytokines that could have been adsorbed are adsorbed, and now we need actually to change the cartridge. Changing the cartridge mechanically is not a very difficult thing to do, because you can just put the machine in circulation and then we can run the circuit all along. But what is prohibitive is the cost. Second is recommendation about torremixin. So torremixin is the endotoxin filter, which is to be supposed to be in the circuit only for 2 to 2.5 hours. After that, it has to be removed and normal dialysis can continue. For Oxiris, it is said that the filter has both the functions, that of cytokine endotoxin removal as well as that of being a hemodialyzer. So after the initial first 4, 5, 6 hours, it has done the job of removing the endotoxin and the cytokines. Then it can stay in the system as a hemodialyzer. So when we are utilizing this therapy ourselves, we have to answer a few questions as to what is the clinical scenario which we are using. Is it a very hypercatabolic patient in which there is very high cytokine levels, and you are utilizing the filter, and we are coming across certain situations like worsening of shock, like worsening of inflammatory parameters, and you think that the therapy is no more helping. Or otherwise, if you are utilizing filters like Oxiris, then it has done its job and it can stay in the system for almost 24 to 48 hours after that. So when to stop the therapy is also a very important question. We utilize a few markers as whether the patient has started in native urine output, whether the inotrope requirement has gone away, whether the overall end organ damage like sensorium, like skin turgor and peripheral perfusion has improved. If these parameters are improved, that means the therapy has done its purpose, and then we can either remove the therapy, or if it has not achieved, then we can replace the filter. But the biochemical or the biomarkers are not telling us about it. Like if say a certain log reduction in the cytokine has happened, then that is the endpoint. The answer is no. If a certain reduction in procalcitonin has happened, and then we can stop the therapy, even that is not helping us.
So in an event where we feel that the patient needs a cytokine filter, a clinician feels on a routine basis that he needs a filter, he is on the therapy. And if we want to replace it, so is there a time interval which is more preferable than doing it on end-to-end continuous basis?
Like in COVID-19, if the patient needs pruning, so you want that the patient can have cytosorb therapy for 8 hours, and the remaining, say 16 hours or so, he can be given a much better ventilation and other physiotherapy. So it almost like acts like a prolonged intermittent dialysis rather than a continuous dialysis. So even that can be done depending on the clinical scenario. But in other situations where you think that there is a continuous focus of sepsis, like that in the lung or the abdomen, which is not yet controlled, and the septic milieu has still not corrected, then giving intermittent cytokine removal will only lead to rebound, and that rebound will not be acceptable and it will not serve the purpose. So depending on the situation, we can utilize it as an intermittent therapy or a continuous therapy. So there are situations where, in fact, like Prashant pointed out, that hemophil can be utilized as an intermittent therapy. So it serves the purpose of removing the cytokines, and the remaining time the patient can undergo imaging and they can undergo physiotherapy. So all these things are not hampered. Yeah, Anand. So the filter actually operates on the principle of adsorption and convection. The diffusion part is only for the small molecules for the diffusion of uremic toxins. So these, because the conventional filters were not as good for removal of these middle or higher molecular weight molecules, that is why the sorbent or the adsorption technology was evolved to cause this removal. Because this has now gone into a concept of ECOS, like extracorporeal organ support. where people are now planning that a single platform can be utilized for extracorporeal CO2 removal also, extracorporeal cytokine removal also, and for maybe in the same circuit ECMO can also be done, provided that the underlying condition is supposed to correct itself in first few hours. So the technology is adsorption and convection.
So I think we thank the organizers, the Nephrology Society, for giving us this opportunity to chair this interesting session. And sir, Acharya sir. Sir, mute है sir आप.
Nishan sir, I have a question.
Yeah, Vishal.
You get involved in those cases when you get a consult for renal replacement therapy, right?
Yes.
So the suggestions of utilizing such filters come from the ICU team, critical care team, or it's your inputs?
So all the initial days it used to come from me, because as we as nephrology consultants want the maximum benefit for our patients when it comes to the uremia correction. We also want that the patient cytokine storm should be corrected. So it was mostly coming from the nephrology end, because the experience also was more from the nephrology end. But as sequentially the therapy getting used more and more, our critical care team is also now getting apprised, and sometimes they upfront call us that come and place a filter. So it does happen.
Nishan, did you had your this experience of doing this earlier at Gangaram?
Sir, Gangaram Hospital, we were utilizing Cytosol because that was available. I got the FDA approval in 2011. So all these other filters like Oxiris and the Toremixin, they have only recently been available. So yes, the connectology part of it, the anticoagulation part of it, that was learned there. But it was only in the COVID-19 pandemic that we wanted that it actually a much more wider use than what was utilized there back then.
Another use is in the abio-incompatible transplant, where we can use cytosol.
Yeah, sir. So in abio-incompatible transplant, there is another gel filter which is known to adsorb the anti-blood group agglutinins. So that is agarose gel filter, and it comes at a cost, very exorbitant cost of 2.5 lakh rupees.
It is not the same as the.
It is not the same as cytosol.
It's a different filter.
It's a different thing. So back there, Delhi people were utilizing this a lot, and of late, even now they have started using it very sparingly, because even with plasmapheresis, they now feel that the log reduction in the isoagglutinins can happen. So the pattern was that first use plasmapheresis as far as possible, and if there is a rebound and the blood agglutinins are not going down, then maybe you can use a gel filter for the ABO agglutinins.
Hello, sir. Hello.
Yes, Prashant.
Yes, sir. Sir, actually, recently one of my patient underwent a ABO-incompatible transplant. There, they have used a glycosoft filter because the values were like 1:128, and cost of ABO, that filter, glycosoft filter, was around 3.5 lakh. Like very high titers of ABO-incompatible or ABO antibodies, more than 1:128, they are generally used.
And did it help him?
This was
Yes,
despite
yes, sir.
plasmapheresis?
No, sir. Actually, at the start only, what the guidelines, Indian study was done. There were three categories. One thing is, if there are low categories, low levels of anti-ABO antibodies, generally they used to use only plasma exchange around 1:4 to 1:16 to 1:64. Then from 1:64 to 1:128, they used to use the double filtration plasmapheresis. And from 1 is to above that, they used to do the glycosorb.
Glycosorb.
Yes, sir. Yes, sir.
Okay.
So that was generally done there, sir.
What was the
And sir,
Yes,
yes, sir.
Go ahead. Please go ahead. Yeah, please go ahead. Yeah, please tell.
Yes, sir. That's what, sir. So that was helpful in rapidly reducing. Like plasma exchange generally it reduces by 30 or 40%. This reduces by around 60 to 70% of anti-ABO antibodies. So that's how it was helpful, sir.
There is also one caveat that when you are targeting these blood group isoagglutinins, whether you are looking at IgM antibodies or whether you are looking at IgG antibodies.
IgG, sir.
So the glycosorb is specifically designed to absorb all the IgG antibodies. While
Yes,
plasmapheresis will remove both the IgM as well
both.
as the IgG. And you don't
Yes,
want
sir.
both on the day of the surgery.
Yes,
So
sir.
plasmapheresis fares much better.
Yeah, IgG. Yes, sir.
Nishant, about the polymyxin B filters, does it also have an antibiotic-like activity?
Sir, it has a polymyxin B embedded into the polystyrene resin. So these antibiotic is embedded into the polymer, which is a fiber, and this has a high affinity for the lipopolysaccharide. So it works on the affinity principle. So it absorbs all the lipopolysaccharide. The lipopolysaccharide load of the person goes down. But meanwhile, the antibiotic activity at the tissue level, whether it is a pneumonia or a urosepsis, that has to be taken care by the conventional antibiotics only.
मनीष आया क्या लाइन पे? मनीष, no, not there.
It was an excellent discussion, and we learned many things from you, Nishant. And you are a prolific speaker, I must say. You had a very difficult task today, and you really did a very good justice to this topic. Thank you very much.
Thank you for the kind words. Actually, this was the purpose to bring to the forum today, so we can have guidance of everybody and utilize these things based, as Ketan sir said, as based on our own experience rather than having somebody else's perspective. So thank you, sir, for your guidance, sir.
And the discussion was also very good. We learned so many new things. So nice of you. And I hope that we go on getting this kind of concentrated syrup of literature. Thank you very much. Keep well.
Thank you.